So anterior and medial thigh and femoral triangle. Don't go. Okay, for the answers, if you want to have the think about it answers, I will post it to Blackboard. So I really hope that you can try to work out your own answer before you check the answers, okay? So L2 here is the learning outcomes for you. We focus on the anterior and the medial thigh and also some of the key attachment and innervation, etc. And also we need to know about the femoral triangle, very important transition zone. And then some important structure inside, which is the femoral shaft, the shaft and the canal and the ring, okay? And then talk a little bit on the femoral hernia, okay? So this is another thing about it. A patient is unable to extend their knee after a deep laceration, deep cut in the anterior and upper thigh. Where is it? Okay. Which nerve is likely affected? And what other functions may also be impaired? Okay. Okay. And then why the femoral triangle is so important? So this is compartment. Now, when we're down to the muscle, we're down to the compartment. So all compartments, okay, let me say, usually, but we must have outliers. Here, every single compartment basically have outliers, okay? But we do believe we talk about the main role first. So each compartment contains muscle with common actions. We do have outliers. Innervated by a common nerve, we also have outliers. Okay, let's take a look. So this is the thigh. Okay, by the way, let us have a very quick spot test with you. What is this? We have something very standalone, a vein. What is this? This is the 係咪好開心啊？答啱咗。This is the great saphenous vein, very standalone, and then running medially, right? Okay, good. So the anterior compartment of the thigh, we're referring to this one here, okay? So they are basically the hip flexor and the hip extensor. So what do we have? We have the peteneus, iliopsoas, the tensor fascia lata, sartorius, and quadriceps femoris. You see, I make many remarks there. Can you see that? So the peteneus here can also be referred to the medial compartment of the thigh. So that's why if you read textbook, you may see other story. I tell you now. Okay, in terms of the location, it is anterior. But in terms of the function, not quite anterior compartment. And also this one as well, we have another muscle called the tensor fascia lata. So later on you will see this muscle again, because this muscle I will group it in the gluteal regions. Why I have to do this? Because this one follow the more versions. More. Okay. And for the medial compartment here, so mainly they are the adductor longus brevis and magnus. And also we have a gracilis. And then we also have a small muscles called the obturator externus. Okay? So the nerve here for the anterior compartment, which is which nerve? Which nerve supply the anterior compartment here? Mainly, which is the femoral nerve, right? So what about the medial compartment? Take a look on the name. Adductor. There's no adductor nerve, but we do have obturator nerve. Okay. So let's take a look on the muscle one by one. Okay? So this is the major hip flexor, So hip flexor, okay? So iliopsoas. Iliopsoas is actually two muscle merged, not merged, because they have a common insertion point. They all insert to the lesser trochanter through the inguinal ligament. So they both have different proximal attachment, but they gradually forming a common insertion point and then attach to the lesser trochanter. Okay, so they are the iliacus as well as the psoas major, because they are quite identical actions that we group together, iliopsoas. So the innervations, the psoas major, iliacus, so all you can see that is L1, L2, and L3. Why I put a bold font size here? So this one tells you that it is the major segment. Okay. So what is the action? So flex the thigh at the hip, just like this one, right? Do the flexion. So when your trunk is fixed, right? When your trunk is fixed, then you flex the thigh on the trunk. When the thigh is fixed, then you flex the trunk on the thigh, as in sitting up, when you are from the lying down positions. Okay? 我扮到俾你睇嘅喎，有冇人可以示範 ？So when you keep your trunk fixed and then you iliopsoas, when you're lying down and you have to bend yourself up like when you hear the alarm. So that one is you fix the thigh and then you work on the trunk. You flex the trunk like you're doing a sit up. I hope I can do the demonstration next year, huh? No way this year I can't do that, okay. Because of these, it also stabilizes the hip joint. It also stabilizes the hip joint. So the psoas major, one note for you, the psoas major is the postural muscles that control the deviation of the trunk and is active during the standing. So one more. So now we are talking about they are doing bilaterally. What about unilateral? If this iliopsoas doing unilateral, yeah, turn your body, okay. Turn. You rotate, okay. You take a look on these, right? Rotate a bit, rotate. So that's why the unilateral contraction assists the lateral rotation. Lateral rotation. Okay, lateral rotation. Oh, let's talk about the outliers. So this is the outliers, the pectineus. So this one innervated by the femoral nerve, L2, L3, but also receive innervation from the obturator nerve. And the action of this muscle, weird. It ADD, close, right, ADD. So when it is in action, so the muscle strength up in this way. So trying to pull the thigh close to the body, close to the midline. So that's why the major action is to ADD, the adducts the thigh, right, at the hip joint. It also slightly help, when you're doing this, you slightly bend the thigh, right, to do the flexion. So that's why the pectineus, we say it is an outliers, okay? Oh, I love this one. You know what is this? You know what is Taylor? The 裁縫啊，Taylor， 你知咩叫？你知道嗎？知啊，嗬。哦，你哋個世界仲有呢個行業㗎，嗬。Okay, very good. So， 嗱，我哋唔 ，so let alone the attachment side. No, just take a look here. How you can achieve this posture? This one. How can you achieve this? So first of all, you have to 哇！呢個真係好難辦啊！呢個。You have to flex your thigh and then out. Laterally rotate, right? You have to laterally rotate your thigh, and then also you have to A-B up. You have to flex, right? You have to laterally rotate. You laterally rotate, and then you have to do this, right? Now I with my hand, right? But if you have to do it in this way, you have to A-B up, laterally rotate, and then flex the thigh as well. What's more? What about your? You still have to like flex the leg as well. So 4 actions together. Then you can take a look on the attachment side now. Well, this muscle is amazing.我好中意呢條 muscle. So this muscle, the proximal attachment site from the ASIS. And then it is the distal part, the distal attachment is to the superior medial surface of the tibia. L2, L3, identical contributions. The action is to flex, abduct, lateral rotate the thigh at the hip joint, and also flex the knee. So that's why altogether it will give you this action, right? Sartorius come from a Latin word. Okay, in the old days they have to do it like this, have the leg cross. If you do medication, 嗰啲打坐嗰啲咧，你隻腳咪要翹晒咁嗰啲咧 ，OK？ Yes. Then you have to have a strong sartorius. This one, another amazing part is this one is the longest muscle in the human. The longest one. 唉，夠啦，走啦，快走。So quadriceps femoris, quadriceps femoris, 4 muscles. So this one, we have the, let's take a look on the name, the rectus femoris. So this one stand alone with a unique terms. And then the rest are rectus, vatus, lateralis, medialis, and the intermediates. So are they the same? Yes and no. The distal attachment sites are the same. They are all to the tibial, they're all down to the tibial tuberosity here. Can you see that? They're all the same, the attachment. But the distal attachment sites, the proximal attachment sites are different. So for the rectus muscles, they all originate from the femur. Can you see that? From the femur. But can you take a look on the rectus femoris? It's actually up to the hip bone, which means that these 3 muscles, they only work on the knee because they cross the knee joint. But for these rectus femoris, this one, they across 2 joints, which means that they can produce 2 actions. Okay? When a muscle across 1 joint, 1 action. 1 joint action. And if it across 2 joints, that it can produce 2 actions. So that's why all these muscle, when it can extend the leg at a knee joint. For the rectus femoris, it can also flex the thigh at the hip because it across the hip joint. Okay, good. And then I want to draw your attention as well. Can you see these 2 colors here? The sign here. So the muscle of the lateralis and also the medialis, they also, these are collective tissues from these 2 muscles, also helps to stabilize the knee joint as well. Okay. Particularly this one. Why? Because remember the COG, the center of gravity, we want to keep our knee in the midline. So actually the soft tissues here can help, particularly this one, can help to retrieve, right? the knee joint more close to the midline, so that to help us stand upright, right, without much extra effort. So here showed you that all these muscles, the quadriceps muscles, they are 1, 2, 3, and number 4, we can see it because it's underneath it. So these are the quadriceps tendon. They embed the patella, and then this is the insertion site. So this is the patellar ligament, and this is the tibial. This one is the tibial tuberosity. Okay, tibial tuberosity. So let me recap. So these muscles, the main action is to extend the neck at the knee joint. But additionally, so these rectus femoris, because it also crosses the hip joint here. Because it also crosses the hip joint here. So it can flex the thigh and the hip. So that's what I want to emphasize. Are they identical? Not exactly. Okay. Then talk about the medial compartment. So the medial compartment, they are all adductors. So the simple functions, they pull the thigh toward the midline. They can also help to stabilize the hip and the lower limbs doing walking and sport. You want to get your lower limbs close to the midline so that we can withstand the pressure and also to distribute the force, right? So that's why I give you 2 points here. The movement and control, move the thighs toward the midline while limiting excessive outward movement. And then the functional role here is to stabilize the hip and leg doing the different like high impact athletic activities. So we have several muscles here. So what is this muscle? That is an outlier. 其實係我年年都唔記得加返個 label 落去嘅。呢個咁係咩嚟嘅呢個 ？Something start with P. Pectineus. Group as in anterior compartment. But functionally speaking, it is adductor. Okay, good. Okay, so let's do it one by one. Okay, by the way, adductor muscles. If you want to be a lady, then you have to train up your adductor muscle. Yes, particularly the gracilis. 以前有個老師會講 gracilis 咧係叫做少女肌啊，唔知叫咩肌 OK， 即係隻腳要夾埋嚟行嘅咧，隻腳夾埋隻腳嚟行。有啲人講話 adductor muscles. If you want to feel your adductor muscles, which activities you can feel it? I don't know, maybe you go to gym and do some exercise to train up your adductor muscles, or horse riding. When you do horse riding, you're exercising the adductor muscles, okay? So the key adductor here, which is the adductor longus, adductor brevis, and adductor magnus. So 長短大. So the proximal attachment sites, they are all to the they are from the inferior ramus of the pubic bones here. So the distal attachment, remember the protruded part, the ridges of the posterior femur. So now we have the linea aspera. So they all attach to the distal attachment to the linea aspera with different locations. If you're really down to detail, so these are the linea aspera to show you different color code so that you can see the attachment site. Okay. Then they receive nerve supply from the obturator nerve. So action, try to ADD the thigh, stabilize the limbs, doing flexion and extension. So we turn rotator hip to the lateral positions. So 3 of them. And then we down to the gracilis. So this gracilis is the weakest of the group. So that's why I checked some literature. Many of them refer this muscle as a potential transplant muscles, right? Say for the hand surgery transplantation. They harvest the gracilis muscles, right? So the same proximal attachment. Then this one, can you see that is actually down to the tibia, the medial tibia, okay? And then the action is, again, the ADD, the thigh at the hip joint, but this one can also help to flex the knee joint at the knee. So you can imagine that if this muscle tighten, so the knee will bang to this side, you will slightly flex the knee, okay? And we also have another small muscles here called the obturator externus, okay? So here you can see the overviews of these muscles. And what I want you to focus on is one thing here. This one. Can you see that the adductor magnus, there are actually 2 portions. I want you to highlight these hamstring part here. So hamstring part is a small part. Adductor part is the major part. But why I need to highlight this? Because adductor magnus is a muscle that actually receives dual, D-U-A-L, dual nerve supply. This is one of the examples. Just like the pectineus, right? Just like the pectineus, it receives both femoral nerve and sometimes the obturator nerve. But this one, majority of them belongs to adductor group, but it does have a small part, which is a hamstring part, which follow the hamstring arrangement. We will touch on this again. Now, femoral triangle. So very clinically important transition region. Now, it is a wedge-shaped space in the superior, medial, anterior thigh. So if you have to attend 4:30 tutorial in BMSB, so you can go now. I will keep the recording, and then you can find the recording in the MFPO, okay? Because I know that some of you have to attend a tutorial, okay? Please go now. I don't want to, all of you? No, okay. So if you have to go, please go, okay? I don't want to be an excuse. Okay, so let's take a look on the borders. Now, these borders is really troublesome. This is the superior border, inguinal ligament. And this is the lateral border, the medial border of the sartorius. And this is the medial border, which is the lateral border of adductor longus. So these, we have the femoral triangle. I give you 2 minutes to settle down first. Okay, are you settled? So please stay if you can. I try to finish as much as I can. Okay? Now, why I need to show you this? Because if you read textbook, there are actually 2 thoughts about the boundaries of the femoral triangle. But as I say, we follow Moore's, so that we have these femoral triangle area to go. So that's why if you see some other textbook, they use what? They use the medial border. No, I draw you now. If you're referring to other textbook, then this is the femoral triangle for the other definition. There's no right or wrong. Some people think that if we follow Moores, the femoral triangle is too small. Yeah. Okay, so let's take a look. And the floor is the muscle iliopsoas and also the pectineus. And the roof is the fascia lata, Okay, the fascia lata. Okay. So remember the analogy or the example I give you. If a stab wound enters this region, so what kind of structures might be injured? And I think big vessels and big nerve. Okay, if you want to stay, then stay. Okay. So then let's take a look on the content. The content. Now the content. We have these beautiful mnemonics for you. Navel. This navel is from lateral to medial. Lateral to medial. N-A-V-E-L. The navel. We have the nerve, artery, vein, empty space, and lymphatics. So we have the nerve here. We have the artery, vein, some empty space, and also the lymphatics here. Let's take a look. I want to introduce you. Remember, as I told you several times already, the outer lining of these is wrapped by the fascia lata. But indeed, in the fascia lata, there is an opening. This opening only accommodates one important big bodies here is the great saphenous vein. So the great saphenous vein drains into the femoral vein through this opening. So the kauta here, the cross here tells you that this is the saphenous opening. Saphenous opening, okay? Then inside it, what do we have? Can you see that there is actually underneath the fascia lata, there is another wrapping of the fascia here, and this one is called the femoral sheath. The femoral sheath. So this femoral sheath cover the femoral artery, femoral vein, and also the deep. These are the deep inguinal lymph nodes, which is medial to the femoral vein. Can you see that? So I try to use the dotted line here to show you these are the femoral sheath, and within the sheath here we have the artery, vein, and also the deep inguinal lymph nodes. They are all encircled, right, by these femoral sheath. It's a funnel-shaped connective tissues, right, formed from prolongation of the transversalis fascia and the iliac fascia. So now here you can see something new. So inside it, like wrapped by the femoral sheath, are what we call the deep inguinal lymph nodes. And then where can we find the superficial one? They are not wrapped by the femoral sheath, and they're outside here. So these are the superficial lymph nodes, right? Superficial inguinal lymph nodes. And then here, I want to introduce another regions for you that they are it is within the femoral sheath, but there is a space. This space is called the femoral canal. Femoral canal, okay? Femoral canal. And at the most medial part, we have this lacuna ligament. So we will go to this slide and explore more about the each of these femoral canal, sheath, and also the ring. So now, this is the right pubic tubercle, and this is the ASIS. This is the inguinal ligament. Remember the navel. We have the A, N, A, V, E, and L. okay? So we have the ring here. So the ring, if we flip this image towards you in 90 degrees, then we have these presentations here. So what you can see is within the femoral sheath, medial to the femoral vein, we have a space. And this space is called the femoral canal. And within the canal, we can find this dot here. The green dot here represent the deep inguinal lymph nodes. Can you see that? 我僭建幅圖僭建得好辛苦啊，因為 Can you see the green dot? So this is originally, the arrows are in the femoral canal, but inside it we can find the deep inguinal vein. I use the green dot here to show you. And on this side, you can clearly see that the most medial attachment here in the site, we have the lacunar ligament, okay? So the femoral canal here, the medial borders here, we have the lacunar ligament. So why we border? So this femoral canal contains the deep inguinal lymph nodes and a few lymphatic vessels. It is important. Remember, if you have to like move your body to whatever positions, so your veins might have to expand a little bit, or the arteries might have to expand a little bit to accommodate, right? To accommodate, particularly for the venous return from the lower limbs when it is needed. And also remember, somehow if you have transiently, you may increase the intra-abdominal pressure, right? It may cause like a temporarily stasis of the vein, inside the vein. So these give some rooms, right, to accommodate any changes if it is required. Okay, so that's why we need to like allow the femoral vein to be expanded inside this femoral canal. And for you, the lacunar ligament is the only boundary of the femoral canal that can be cut during surgery. Why we need to cut it off or cut it to a certain extent is because of the femoral hernia. So if it is the case, care must be taken when doing this, as up to 25% of people may have an aberrant obturator artery. The Latins, they call the corona mortis, which can cause significant bleeding. Let's go to page 18. This shows you the ideas. You can go to this slide and have a look. So this one is the aberrant obturator artery. So it may form here, and then if you have to repair of these femoral herniation, you may have to cut it open. If that is the case, it might somehow, can you see the artery here? Okay. So if when you do this later on, you must have to check whether the patient will have these abnormal variation in the arterial blood supply. Okay. So that's it. This part. And the femoral artery, very important. There is a landmark. You can locate it. So with the use of the ASIS as well as the pubic symphysis here, the pubic symphysis. So ASIS and the pubic symphysis halfway through, you compress it, then you can feel the pulse. So the pulse diminished with partial occlusion of common or external iliac artery. So if there is something wrong here, not good circulation, you may feel the pulse here being diminished, not strong enough. And then compression site here, we can control the bleeding following trauma. Okay. And then it could form an access, right, or to the left cardiac angiography or to the coronary arteries. through the femoral artery to go. So basically, femoral vein cannot be feel, right? You cannot find the pulse, right? But with the navel, the location that you know it, if you can find the artery, medial to the femoral artery is the vein, okay? And also, the femoral vein is also a good site for you to apply the catheter, right, to the right atrium. And also the femoral nerve, the nerve is lateral to the femoral pulse, okay? If you can't remember it, take a look on these slides. The trick is how to locate it. And if you can find it, you can find the vein, and you can find the nerve as well, okay? So the herniation. So the herniation, talk about the indirect inguinal herniation, was taught by Professor Pauli. So protrusion via deep and superficial inguinal veins to the scrotum. So I'm not talking about the inguinal things, but here I just want to highlight one thing is, if you suspected someone with indirect inguinal herniation, the sac, the abnormal mass, right? The sac appears above and medial to the pubic tubercle. That is what I want to mention. Above. What if it is a femoral herniation? The sac usually find it below and also lateral to the pubic tubercles. That forms difference. Can you see that? And femoral herniation are more common in female, as femoral canal wider, simply because women have a broader pelvic arrangement. So because of the pelvic shape, wider in size, so that will make chance where for the women to develop, got a high chance to develop femoral herniation, okay? If you want to have another view, I like this one. I know that some of you are very science geek to read big paper. This is the one for you. This one, you have another presentation to show you the arrangement, which is nice. I quite like this one, okay? And it shows you the ABC locations, right? For the details, you can scan the QR code and then have some lesser reading time, okay? Adductor canal. So it is an aponeurotic tunnel in the middle third of the thigh. It runs from the apex of the femoral triangle and then down to these openings here, which is called this one here, is called the adductor hiatus in the adductor magnus. So anteriorly, so this one shows you the boundaries. So anteriorly and the lateral, you find the muscle, right, the vatus medialis, and then posteriorly, it is formed by the adductor longus and magnus. It is covered by these like strong or broad, right, aponeurosis, and also covered by the sartorius. What is the content inside? We have the femoral artery, vein, and nerve, right? So the femoral nerve, actually, when it get into the adductor canal, it already presented as a form as the saphenous vein. Then where are the femoral nerve? The femoral nerve supply the anterior compartment. So that's why I can show you this again, this image again. Yeah, this is a good one. Can you see that? This is originally the femoral nerve. It's actually, once it like descend a little bit, they've already divided to many branches because they go to the quadriceps. There is only one remaining nerve as a form of, as a saphenous nerve, and then it will down to the adductor canal, okay? It will down to the adductor canal, and also one nerve, which is to the vastus medialis. Okay, so this is the adductor canal. So the so the femoral vessels pass through the adductor hiatus. So later on, can you see that there is a small openings here? So this small opening is called the adductor hiatus. If you want to see adductor hiatus better, you can go back here. Can you see that there's an opening? Can you see that? There is an opening. So this is adductor hiatus. This one is also adductor hiatus. And you follow. This one adductor hiatus. So you can see that everything is moving from relatively superficial and then descend and then go to the bone level. And then from the anterior compartment, and then they will pass through the adductor hiatus and then go to the back. Go to the back. Go to the popliteal regions. Okay. I think I cover this part. Okay. So before we down to the nerve, I need to jump to embryology a little bit, because in the uterus, the lower limb buds grow out laterally, but it then internally rotates, like in this way. So that's why, okay, let me repeat. So in early development, the lower limbs grows out and then internally rotate. So that's why the knee extensors end up on the anterior thigh, right? And so this is one of the reasons why the compartment layout look like in this way. Take a look here. So that's why, so the something is like turn. We have a 90-degree turn, right? What's happened? So the femoral nerve actually is go to the front, but it is from the posterior division, right? And for the obturator nerve, it is originally anterior divisions, but then it turned medially, so it becomes a medial. So I want to show you this, okay? Because this is unique in lower limbs, not in upper limbs, okay? So that's why the obturator nerve now become the posterior or even the medial aspect, whereas the femoral nerve originally is the posterior division, now it turn, become the anterior divisions, all because of the internal rotation during the adaptation, right, for us to walk so that we can stand upright with two limbs, okay? Okay, then we can down to the obturator nerve. Where is the obturator nerve? Where is my obturator nerve? 唔見咗條 nerve 嘅點解？哇，好怪啊！ Okay, so it forms from the L2 feet and 4 spinal nerve. Here, I'm sure every one of you should have touched the obturator nerve in your dissection. It's running quite deep and then swing around the interior of the pelvis and then through the obturator foramen, and then it leaves and then go to the thigh. And then it actually have like 3 divisions. First, anterior branch. So this is the anterior branch. So anterior branch, this is the anterior branch. Okay, so the anterior branch supply the adductor brevis longus, pectineus, and gracilis. The posterior branch will supply the obturator externus and adductor magnus. We also have a branch to supply the joints. So that's why it's called the articular branches, to the hip and to the knee. So that's why sometimes pain from the hip joint may refer to the medial side of the thigh or even down to the knee joint, because the obturator nerve supplies both of these joints. Sometimes they can't tell the real origin of the pain. They mix up, okay? So the obturator nerve injury can cause a weak hip adduction, okay? And then we down to the femoral nerve. The femoral nerve is the big nerve for the anterior thigh. It is the largest nerve of the lumbar plexus. It mainly comes from L2, L3, and L4. It supplies the anterior thigh muscles and the skin on the anterior medial thigh. It continuous as saphenous nerve here, okay? Traveling with femoral artery and veins in the adductor canal. Then it will supply the skin on the anterior medial knee. Can you see that? This one. show 俾你睇先。哇，好細字，我睇唔到。This one, you see this is the saphenous nerve. It's in the medial supply the cutaneous sensations, right, of this region. And let me recall you, there is something running up in this way. And when you puncture it, sometimes the saphenous nerve will make complaint. That is the GSV. Remember that, okay? Good. Good. So it terminates at the saphenous nerve, okay? And then the femoral nerve injury results in weak knee extension, so difficult walking and loss of the patellar reflex. Patellar reflex. 呢個知啦啩？呢個得唔到自己㗎，我扮下先。Patellar reflex. Patellar reflex. Okay. So compression of the femoral nerve in the pelvis. Now, just like what you've learned in your upper limbs, okay? Different points we can apply injury or apply compression or problems at different levels. So the femoral nerve, if the root problem is very up, right? It could be like in the pelvis. So it can occur due to like maybe hematomas, tumor, or some surgical complications. So it make irritate the femoral nerve and make the quadriceps muscles altogether doesn't work well. And then you may also result in weak patella or loss of the patellar reflex as well. So then down to the arterial supply of the thigh. This one, very important. So you see, this year I add one more slide for illustration. So I hope you can grasp the idea better. Take a look first. This one, I start with the obturator artery. So this obturator artery, when you do dissection, remember there is a small arteries running next to the obturator nerve, not big in size. So then you can imagine, obturator nerve, let me rephrase. 好彩呢度有得 cut 嘅啫，睇先，唔好意思啊，我剪片嗰時影得到 ，OK。So the obturator artery follow the obturator nerve. You should know that the size is very small actually. So how come it can nourish the adductor muscles? It's no way. No way. Okay, so there must be other big vessels to supply these muscles, right? So we will talk about it. But the obturator artery, we say that it is continuation of the internal iliac artery. So supposedly supplies the medial compartment. But this one, you should make a note here. Not sole supplier. There are other arteries, right? Also supply the medial compartment. So then down to the big brothers here, femoral artery. Continuation of the external artery here. So this is the external artery, external iliac artery, and then it down to the femoral artery. So it then, when it descends, first it will branch off the deep femoral artery. If you don't mind, do it in this way. So this is the femoral artery, right? Then it further down as the femoral artery, but indeed it branch off a deep femoral arteries here. And then this deep femoral artery will have several branch off. The MCFA, the LCFA, and also 3 to 5 branches of the perforating arteries. Okay, so the deep femoral artery, right, arises in the femoral triangle, passing deep to the adductor longus. So in dissection, try to take out the deep femoral artery, the bifurcation of this, if you can, okay? Then later on, it form 3 to 4, some textbooks say 3 to 5, just several perforating arteries to supply the adductor magnus, supply the hamstring, the posterior muscle of the thigh, as well as the ratus lateralis. Don't forget, now let me enhance it a bit. So this is the deep femoral artery. Actually, it also bifurcates from the MCFA and also the LCFA as well. Now, let me show you here. So this is the femoral artery, and then bifurcate into the deep. And then for the deep, it further divided into the LCFA and the MCFA. And further down with several of these perforating branches. Can you see the story? So, basically, you can assume that what we see in the thigh, inside the adductor canal, is the femoral artery that's got no job to do with the thigh. They are as a bundle, they are as a unit, and then descend down, and then down to the popliteal regions. And then it starts to work. Okay? For the thigh, for the whole thigh, basically, it's supplied by the deep femoral arteries. How? How to make it happen? Like this one. Oh, this one first. So this one, you can see the story better. So the first one here is the femoral artery. You see? No major branch off, and then through the adductor hiatus, and then go to the back of the knee. And then here, this one is the deep femoral artery. You see that there are several branch off, and then also different perforating branches, and to supply the big muscles, the muscle populations of the thigh. And then we have also the small one here, the obturator. So for your information, the obturator artery and also the obturator nerve, they kind of like bifurcate, right? In front of and posterior to the adductor brevis. This is the anatomical landmark. So here you can see that the deep femoral artery give 3 to 5 perforating arteries that pierce the adductor muscles. Can you see that? It actually, so this is the deep femoral artery, and then it further divided into the perforating branches and pierce through the adductor muscles, right? And then to supply, right, to reach the posterior thigh and supply the hamstring as well. So that's why it forms, these perforators can help to form the anastomosis. So proximally with the gluteal and also the circumflex femoral arteries, and distally with the branches around the popliteal regions. We would like to provide, right, better collateral flow if the femoral artery is ligated or occluded. Okay, so this is the original ideas of having this. Yes, and this is the last one. I want to introduce this anastomosis for you, which is called the cruciate anastomosis. Does it look like a cruciate 十字架似唔似啊？唔似。It's called the cruciate anastomosis. So for the cruciate anastomosis, so let's talk about the members. The member is starting from the inferior gluteal artery, MCFA, lateral circumflex femoral artery, and also the first perforating arteries. Why is it important? Because if there is obstruction of the external iliac or femoral artery, so let's do a categorization here. Let's do it together. Inferior gluteal arteries is from which immediate blood supply? Yes. Internal iliac artery, right? Am I right? And for the medial circumflex is from deep femoral artery. Deep femoral artery is from femoral artery. It's from the external iliac artery. This one is in external iliac artery. This one also external iliac artery. You can say in this way, which is the femoral artery or a deep femoral artery. 我會寫 D 曲咁喺度，冇上堂唔知我講乜。Okay, deep femoral artery. Okay, so here tells you that if there is an obstruction of the external iliac or femoral artery, so we still have a way to bypass the problems. So that's why we have these cruciate anastomosis. Very important for lower limbs. Okay. Thank you. And then please find the answers on Blackboard. I will post it maybe tomorrow. Okay, thank you.